Welcome to Medicine, A to Z, your comprehensive guide to health conditions. Today, we're diving into a common respiratory issue, acute bronchitis. Acute bronchitis is an inflammation of lower respiratory tract caused by infection involving the large airways, bronchi, without evidence of pneumonia, that occurs in the absence of chronic obstructive pulmonary disease. When it comes to acute bronchitis, viruses take the spotlight as the primary culprits behind this respiratory condition. The viruses commonly associated with acute bronchitis are Influenza A and B, Parainfluenza, coronavirus types 1 to 3, Rhinoviruses, Respiratory Syncytial Virus, Human Metapneumovirus, Severe Acute Respiratory Syndrome Coronavirus 2, SARS-CoV-2. Bacteria are uncommon causes of acute bronchitis. The bacteria most commonly associated with acute bronchitis include Bordetella pertussis, Mycoplasma pneumoniae, and chlamydia pneumonia. There is no convincing evidence to support the concept of acute bacterial bronchitis caused by pathogens such as Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenzae, Moraxella catarrhalis, or other gram-negative bacilli. Symptoms and signs of acute bronchitis. Symptoms of acute bronchitis often appear suddenly and may include acute onset cough, a persistent cough that develops rapidly and might linger for weeks. Sputum production. The cough may bring up thickened mucus or phlegm. Other symptoms may comprise of fever, chest tightness, wheezing, audible whistling or squeaky sounds during breathing, fatigue and body aches, vomiting and diarrhea. On examination, certain signs can aid in diagnosing acute bronchitis. Rhonchi, inflamed throat, pyrexia, diagnosis of bronchitis. Bronchitis is primarily diagnosed through clinical assessment. This process involves a comprehensive approach, including detailed history taking and thorough physical examinations. One of the key elements in diagnosing bronchitis is obtaining a detailed medical history. This involves inquiring about symptoms such as cough, sputum production, chest discomfort, and any associated factors like recent illnesses or exposures to irritants. Physical examinations play a crucial role in diagnosing bronchitis. Healthcare providers perform auscultation to listen for abnormal breath sounds and assess the patient's overall respiratory health. While clinical assessment forms the cornerstone of diagnosis, there are circumstances where investigations become essential. One primary reason for investigations is to rule out alternate diagnoses, especially conditions like pneumonia. In cases where symptoms overlap or there's suspicion of a more severe condition, further investigation becomes crucial. Understanding the role of chest X-rays in bronchitis and pneumonia is crucial for accurate diagnosis and effective management. In cases of acute bronchitis, a chest X-ray typically reveals no significant abnormalities. However, when clinical suspicion of pneumonia arises, obtaining a chest X-ray becomes pivotal for precise diagnosis and proper management. When there's a suspicion of pneumonia, certain indications prompt the necessity for a chest X-ray. These indicators include abnormal vital signs, such as a pulse exceeding 100 beats per minute, respiratory rate surpassing 22 breaths per minute, a temperature above 38 degrees Celsius, or oxygen saturation below 95%. Signs of consolidation on chest examination. Healthcare providers look for abnormal findings during chest examinations, such as crackles or reduced breath sounds indicative of consolidation. Mental status or behavioral changes in patients over 75 years old who may not exhibit typical fever responses but might display alterations in cognitive functions. While chest X-ray findings may be unremarkable in bronchitis, its role becomes pivotal in suspected cases of pneumonia. Sputum bacterial culture, though commonly associated with diagnosing bacterial infections, isn't typically recommended for acute bronchitis. Bacterial pathogens causing acute bronchitis are rare. Therefore, sputum bacterial culture may not yield significant findings for diagnosis or treatment guidance. Similarly, routine viral identification is usually not recommended for diagnosing acute bronchitis. Identifying the specific virus causing bronchitis does not typically alter the management or treatment plan for the condition. Testing for influenza is advisable for individuals at high risk for complications or hospitalized patients with acute bronchitis. Differential diagnosis of acute bronchitis. When diagnosing acute bronchitis, considering various potential causes for acute cough becomes essential. Let's explore the differential diagnosis of acute bronchitis to ensure a comprehensive assessment for similar conditions. Pneumonia shares similarities with acute bronchitis in terms of respiratory symptoms. Distinguishing features often include fever, chest pain, and a more severe illness. Asthma presents with recurrent episodes of wheezing, shortness of breath, and chest tightness. It's crucial to differentiate between asthma and bronchitis. COVID-19 manifests with symptoms like fever, fatigue, loss of taste or smell, along with respiratory symptoms. Testing for COVID-19 might be necessary, especially during outbreaks. GERD, or gastroesophageal reflux disease, can present with heartburn and regurgitation. Some patients may experience cough as the sole symptom, requiring careful evaluation. Heart failure often presents with cough, particularly with exertion or while lying flat, along with shortness of breath and swelling in the lower extremities. Pulmonary embolism, a blockage in the lung arteries, may lead to sudden cough, chest pain, and shortness of breath, often accompanied by other concerning symptoms. Managing acute bronchitis focuses on symptom relief and patient education. In most cases, symptoms resolve on their own within 1 to 3 weeks. Symptom control. The primary goal of treatment is to alleviate symptoms. This includes resting, staying hydrated, and using over-the-counter medications for cough and fever if necessary. Educating patients about the self-limiting nature of acute bronchitis is crucial, stressing the importance of hydration, adequate rest. It's important to note, antibiotics are not routinely recommended for acute bronchitis. Since the condition is primarily viral, antibiotics are ineffective and may lead to antibiotic resistance. In summary, a patient-centered approach involving symptom relief, education, and the avoidance of unnecessary antibiotics is key in managing acute bronchitis. Remember, for most cases of acute bronchitis, time and supportive care are the best remedies. Patient education in bronchitis involves imparting vital information about the condition to enable patients to understand its course, treatment, and the importance of appropriate care. Course of illness. Treatment plan. Reducing inappropriate antibiotic use. Overall, patient education in bronchitis aims to empower individuals to understand the natural course of the illness, adopt appropriate self-care measures, and make informed decisions regarding treatment, particularly concerning antibiotic use, to optimize recovery and avoid potential complications. Managing symptoms in acute bronchitis is key to easing discomfort and aiding recovery. Symptom control involves a multifaceted approach, addressing hydration, rest, medications, and inhalers to alleviate discomfort. Staying hydrated by consuming 8-12 glasses of water daily helps to thin mucus, making it easier to expel. Adequate hydration is vital for managing symptoms. Rest is crucial. Allowing the body time to recover supports the immune system and aids in combating the illness. Using a humidifier or steam inhalation helps to moisten the airways, providing relief from cough and facilitating easier breathing. For accompanying cold symptoms, pain relief medications like acetaminophen or nonsteroidal anti-inflammatory drugs can help relieve headache, malaise, and muscle or joint pain. Over-the-counter medications such as dextromethorphan or guaifenesin can help manage cough. However, caution is advised with patients taking selective serotonin reuptake inhibitors, SSRIs, due to potential interactions. Inhaled beta agonists like albuterol can assist with wheezing, especially in patients with underlying pulmonary disease. It's important to reserve their use for patients displaying specific symptoms. The role of antimicrobial therapy in acute bronchitis varies based on specific circumstances. Antimicrobial therapy is typically reserved for specific cases where a particular pathogen is suspected or diagnosed. Additionally, it's considered in patients at high risk for complications. For influenza, treatment with neuraminidase inhibitors like oseltamivir or zanamivir is reserved for hospitalized patients or individuals at high risk for complications. In cases of clinically suspected or confirmed pertussis, antibiotic therapy is recommended, particularly in patients with cough lasting up to 3 weeks. It's also suggested for pregnant women experiencing cough for less than 6 weeks. In specific cases where acute bronchitis coexists with underlying asthma, a short-term course of steroids may be recommended. This aims to reduce inflammation and improve breathing in these individuals. Complications of acute bronchitis. While acute bronchitis often resolves on its own, it can lead to several complications, particularly in vulnerable populations or individuals with pre-existing health conditions. Following acute bronchitis, some individuals might experience a lingering cough that persists for weeks to months after the initial infection has resolved. This chronic cough can significantly impact quality of life. Acute bronchitis can weaken the immune system, increasing susceptibility to secondary bacterial infections like pneumonia or sinusitis. This risk is higher, especially in individuals with compromised immune systems or underlying health conditions. For individuals with chronic respiratory conditions such as asthma or chronic obstructive pulmonary disease, COPD, acute bronchitis can worsen their existing symptoms and lead to exacerbations, necessitating additional treatment and care. In vulnerable populations such as the elderly, infants, or those with weakened immune systems, acute bronchitis might pose a higher risk of complications. This can potentially lead to hospitalization due to respiratory distress and increased susceptibility to severe outcomes. Understanding acute bronchitis is essential to navigate its course and management effectively. Here are some crucial take-home messages about this condition. Acute bronchitis, predominantly viral in origin, stems from viruses in about 95% of cases. While it's a self-limiting condition, the persistent cough may endure for up to 3 weeks. It's crucial to rule out other potential causes of acute cough, ensuring an accurate diagnosis and appropriate management. Break of host defenses can lead to secondary infections, possibly causing pneumonia. This highlights the importance of monitoring symptoms and seeking timely medical attention. Steroids and beta agonists are typically reserved for individuals with underlying lung conditions, addressing exacerbations, or managing symptoms in these specific patient groups. Complications can arise, and some individuals may experience prolonged cough lasting beyond 3 to 4 weeks, warranting further evaluation and care. For healthy individuals without complications, antibiotics are not recommended. However, there's a role for antibiotics in immunosuppressed individuals, extreme age groups, and those with comorbidities. In summary, understanding the nature of acute bronchitis helps in navigating its course. Timely assessment, cautious medication use, and seeking medical advice when necessary ensure better management and care. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.